How about yours? No. Do they know?
We don't, oops, let me run up there.
Oh, here. Hello? I think, oh, we're okay now. How about yours? Not sure. I don't think theirs is working well. Is it on? It's on. Well, do you see the light? Do you see the little thing on the microphone?
How's that?
That's better. It always helps to put on the switch. Okay. Again, calling this meeting to order. It's Thursday, March 7, 2024. This is the annual work session meeting in Mohave County Employee Benefit Trust Fund Board of Trustees. Clerk, I believe we have a quorum, and everyone's here. Nobody's on the phone. Good. Okay, official business to come before the EBT board. There is a call to public. Anyone here? Okay, we're going to close the call to public. Opening remarks. Go right ahead.
Thank you, Madam Chair. Trustees, good morning. Thank you for your time today. Excited to be here for the annual renewal meeting. We got a pretty packed agenda, so we'll get to it here pretty shortly. But what we'll be running through is we have some vendor presentations to go over through some data, how the plan's going from medical, RX, and so on. And then we'll get into the budget and the rates for the upcoming 7/1/24 plan year. So again, thank you for your time today, and I'm happy to be here.
Okay, any questions or comments? All right, we will move on. Medical claims reviews, overview of Aetna Network and Teladoc.
Good morning, everybody. Thank you, Madam Chair, trustees. Good to be here. It's been a year.
Can you tell us, for the record, your name?
Yes, I was just about to introduce myself. Thank you. I am Rick Seithamo, the account director at Meritain Health, and I'm here to present to you your medical claims trends for 2023, basically the calendar year 2023, as compared to the calendar year 2022. I'm only allotted 15 minutes, so if you're going to take anything away from you today, I'll summarize real quick before I get into the data. What we're seeing is a couple of things. Both of them have to do with COVID. If you recall, during COVID, we kind of predicted what might happen. First one was, we called it was deferred care. What we were seeing during 2020 and 2021, that people were not going in and getting their preventative services done, or if they had any kind of elective surgeries, those things were kind of getting pushed off as well. So what you're finding is that because people weren't catching things at early stages, then you have where there are actually more complicated services happening right now. So that's what's actually happening. And it's not just Mohave County, we're seeing it throughout the industry. The other thing is that during COVID, a lot of providers, specifically healthcare systems, took a lot of hit revenue-wise because all they were doing was taking care of just COVID situations. All those elective surgeries, things that they bank their profits on, were being postponed. So during that time, and I'm sure that Rachel will start talking about it as well when she comes up here and talks about her Blue Cross Blue Shield network, but a lot of contracts were up with these providers, and because they lost so much money, they've come to us and they've threatened to term from the networks, and they wanted higher pay, wanted the discounts to be a lot less, so that there's more money coming to them rather than out of your pocket. So that's what we've been doing. That's why you lease both the Blue Cross Blue Shield and the Aetna networks, is because we are here to fight for you, to try to get you better discounts. What we're going to start doing is it's called value-based contracts. It really hasn't hit Arizona, except there is a performance network that kind of does it already, but it's going to be about rewarding providers for their performance rather than a fee for service. Kind of like a mechanic. You go there and you go there for one wrong thing, and then next thing you know, we're going back in next week, the week after, and stuff like that. We're trying to get doctors away from doing that to keep you coming in. We want them to treat the symptom and keep you out of the hospital. So that's what we're kind of going to. Any questions before I move into the data?
I have a question.
Yeah.
So what you just said, about rewarding, they did the same thing with access, and they found that it made everything worse because people, they're not coming back because the doctors aren't seeing them. I mean, is there any studies about sort of the unintended consequences of that model?
Well, what we were seeing in the performance network, and I know what you're talking about with access and Medicare, they all went to that. We have seen where if you're rewarding the primary care physicians. Now, it is harder to get in to see some of them because not all of the providers are doing it. So it did limit your access to your providers. So that's probably what you're talking about, is that people
I'm
just...
saying that, the doctors, if you have a procedure and you have a follow-up care that needs to be done or it didn't work the way, the doctors aren't seeing you because they're not going to be paid because it's by performance. I just have a sort of a moral issue with that.
Oh, well, so what we do have some down in the valley that are doing the performance network, and we do see that those are being successful. And it's not that the doctors don't care, because they do get rewarded at the end. It's just that they don't get paid right away. So if you have doctors that I know I need the money right now, I have mortgages to pay. Yeah, you might have where those are the upset ones, and then guess what? They're no longer part of that system anymore. So it's just the ones that are actually doing it that are actually still being rewarded. So there are some, every story has two sides, right? You're going to have some where it doesn't work and then some where it is working. So,
Well, I mean, they're not being rewarded, they're being punished, but
well, yeah, we'll agree to disagree on that. I mean, I'm not saying that you're wrong. I'm just saying that, there are some providers that, don't like it. So I appreciate that. Any other questions or concerns before I move on to the data?
Berlin?
Chair, I have a question. You say that we're seeing these increases because of COVID. Now everybody's flocking back to the doctors to have their procedures or whatever. Do we think that we've seen these, or are they going to continue for another year or two or whatever? We've taken a hit this year.
Right, exactly. And you're not the only one that's taken the hit. We're hoping that it is towards the end of it. But then again, it depends on the population, who's been managing their health. If you have members that are still afraid to go to see their doctor and they wait another year or 2 years later, we might find something in and get hit still. We do feel that this is the biggest impact year, and we do feel that it is kind of going to settle down. But again, it just depends on the actual specific member and how they're treating themselves. So what we obviously want to do is encourage people to take care of themselves, really notice what's going on with their body and get in to see their doctor to do preventative services. You're welcome.
Okay. Anyone else? Any questions?
Okay, thank you. So I'm just going to move into the executive summary then. We'll start with your demographics on your membership. We did see a drop in how many members you had on the plan. Is that what this is? So that everybody can see it? That's why I brought mine up. I wasn't sure if this was going to be on or not. Can I use this to advance? Please bear with us. I get to be the first person up here to deal with all this. All right, there we go. Now I don't have to use my iPad. That's great. Okay, so again, using the demographics, you did have a drop in membership compared to 2022. We do break out how your plans are being utilized. The majority of your members are in that EPO plan. So because of that, if you look over at the employee cost share, it's only at 13.3%. Usually other clients that we have, if they have more than that plan or more high health plans, they might offer more. You only have 19% of your memberships on high health plans, but if you have more members in that, you're going to see that the employee cost share is going to be a little bit higher. This does not take in consideration premiums. This is just looking at their out-of-pocket costs that they pay at the doctor's office. So because of that, you are relatively low compared to a lot of our other book of business. Even though right here it shows the 13.9% for our book of business, I've seen it as high as 17% for some of our clients just because of the high health plan. To normalize things, we look at the per member per month. So how much are you spending per member per month? Because your population did drop, but we want to know, does that make how much you're spending on each member? That should go, you would think it would go down because you have less members, but that's not the case here. We're actually seeing where the cost per member is actually going up. And it goes back to what I was saying before, because there's a lot more services that are happening that are higher cost services. And then we also have where doctors are wanting to get paid a little bit more. So when they did renegotiate the contract, they even though we didn't give them the 30% they were asking for, they're still getting probably a 15% increase. So that's going to impact your claims because they're getting paid a lot more than they were 2 or 3 years ago. If you look down at the medical trends, this kind of shows you that. Right there, you can see that your claims and your claimants, so there's less utilization, not as many people utilizing the plan, and not as many claims hitting the the claims processing. But as you can see, your plan paid about 13% more than it did the prior year. And then a lot of that has to do with because, again, higher cost services and the doctors getting more. Looking at your high cost claimants, you have about 19 members that had claims over $100,000, which represents about 33% of your claims. So again, that's less than 20 people on your plan that represent a third of how much you're spending. And again, it goes back to those high cost services that are going on. If you take a look at what it was a year ago, you only had 10 members over $100,000. So, you're wondering like how you got hit so big. Well, you had 9 more members, but even though the 10 people last year represented only 31% of yours. So it's still, you kind of look at it and go, well, 9 people, you would have thought it would have gone up more. But the fact is that all those other claims under $100,000 are a lot more than they were before. So when you look at the relativity of how much spend is going towards your high cost claimants, because your lower cost claimants are still a little bit more, that's why you only see 33% compared to the 31% last year. Hopefully that didn't go over your head too much. Average medical savings, I'll let Rachel talk about Blue Cross Blue Shield, but Aetna, because that's why I'm up here, I will let you know that you had about 200 more claims go through on the Aetna network. People really are utilizing that. A lot of them are going over to Nevada. And we did see that you're getting a healthy 74% discount. So basically every dollar you pay in access fees to have that Aetna network that covers you in the other 49 states, you're getting about just over $82 back in savings and discounts. So it's a good investment that you guys have there, and it's good access that you give to your employees so that they're not stuck just in the state of Arizona. Any questions on this slide before I move forward?
Any questions? No, you can move ahead.
All right, so the next slide, the thing that we're going to pay the most attention to is your top diagnostic category per member per month trends. Your musculoskeletal and your endocrine. Musculoskeletal, it just had a slight increase, and that's due to some surgeries that were happening with knee surgeries and things like that. The endocrine, that has a lot to do with your diabetes. A lot of diabetic members that, again, that deferred care that I was talking about, they didn't take care of themselves during the pandemic. So they had some major surgeries and services that were done for those people that allowed their diabetic symptoms to go out of control. So that's the biggest one right there. The factors influencing health status, a lot of that is tied to cancer claims, which again, I told you about before, is that people weren't doing their preventative services, so they're catching things at a later stage. But what's also in that factors influencing health status is your preventative services. So people are actually getting back into their primary care physicians and getting the preventative services done. So hopefully with those being done now, back to your point earlier, Hildy, is will we start seeing the claims kind of come down? Hopefully we're catching things at early stages now. So that's what we're hoping for. Looking at your inpatient trends and your outpatient trends, again, it goes back to my point earlier that you have less claimants and less visits happening, but the services that are occurring at the hospitals and your outpatient services are costing a lot more. If you look at that number right there, for the inpatient stays, the amount per admit is about 14% higher than it was a year before. And your outpatient is an alarming 43% higher per visit. And a lot of those are your chemotherapies and some of your surgeries with aftercare, and then of course some of our diabetes that things happen in the outpatient services. So any questions on this slide before I move forward?
Sam Elton.
Madam Chair, thank you. My question is reflecting on the comment that you made earlier, which is the COVID deferred care.
Deferred care, yes.
And then looking at the inpatient trends and the outpatient trends, both declining. So looking at the numbers, it doesn't correlate with the notion or the thought that there was return to care after COVID, because those numbers are down.
So the claims are down. Yeah, so the claims are down, but the services that are occurring at the hospital, so we're having less people that are using the services, like for hospital stays and outpatient surgeries and things of that nature. We have less of them happening. However, the ones that are happening are more expensive type services, and it's because they weren't taking care of themselves. So again, back to my point of like, if you caught a cancer, you got some sort of a diagnosis of cancer, now you're at a stage 3 rather than a stage 1 or a stage 2. Those are going to be more costly of services that you're going to be taking care of yourself. Diabetics, if now all of a sudden you have to have an amputee, you have a leg cut off, that's going to cost a lot more than what 10 claims were the prior year. So because you have less claims does not mean that you're going to be spending less. It means that the claims that we are seeing are because they're higher cost services. They're the types of services that cost a lot more money than they would have a few years ago if they would have just taken care of themselves during that time. Does that make more sense and clarify it? Okay, you're welcome.
Anyone else?
Okay, so like I said, I already had the summary of like what's going on. I have some recommendations here. The orthopedic aftercare, that was what we saw in the factors influencing health status, also was a trigger for that. We had 8 members that accounted for almost $500,000 in paid claims for that category. So again, those are your knee surgeries, hip surgeries, things of that nature, which also fall under musculoskeletal, which was one reason why I referenced the musculoskeletal. If we wanted to, we should be able to encourage the people to utilize Hinge Health. It is a benefit that you guys offer. I just don't know if there's enough communication to let these members know that this is the best way to take care of themselves in the stretch, and to maybe do even aftercare physical therapy at home rather than traveling to go get it done. A lot of times you find that if people aren't taking care of themselves after they have a surgery with the physical therapy, they end up re-injuring themselves and then having to go back in and have something done. So this eliminates that fact. And then the other part is the type 2 diabetes cost. We did see that as an increase. It went from $137,000 to $613,000 in those types of claims. So again, back to that point of less claims, but they're just highly cost claims because of the services being done.
Can you give me an example of that? Like, what would be a service that is so much more now, and what would be the reason for that?
Well, if you were basically working, you have a diabetes as your diabetes type 2 is your diagnosis, and you're managing it, you're doing your finger pricks, you're taking care of yourself, you're managing your all your levels, then you're going to be fine. But you're going to still have some claims. You're going to have claims where you're seeing your doctor. Let's say that you weren't managing yourself, and next thing you go into some sort of a shock, and then you go to the hospital, and you have where amputees, where they have to cut off your leg, things of that nature. So you have surgeries that are a lot more costlier because of the diabetes type 2 if you're not taking care of yourself.
So this number, the costs are associated with this 8 member? Is that what I'm confused.
Not just the 8 members, that's the one for the orthopedic aftercare. So that's like hip surgeries and knee surgeries. The one down below, the cost for diagnosis, that could be more than just 8 members. I could get you that number of members, but it's a lot more members. But there were about, I think, 5 that had some major surgeries done because of their diabetes.
Okay. I just honestly, I think it's confusing. So if you're saying for the same cost for this diagnosis increase from 137, so that for the same services that
not the same services for this diagnostic category, you have type 2 diabetes, and your endocrine category was how much Mohave County spent in total claims, no matter what the services were. The services were probably people going to their primary care physician, taking care of their diabetes.
All right, I understand this.
Okay, yeah, so now it's the same diagnosis. You're spending a lot more on that diagnosis, not the same services. Thank you for having me clarify that.
Okay. And anyone else?
So it's not just a cost increase by the hospitals or doctors. It's
the type of services that are happening, but it's a combination of both, right? So let's say that in 2020 or 2021, if you would have had a service of, let's say, amputating, having surgery, leg being taken off, probably wouldn't have cost as much as it does now. But I'm not saying that, $100,000, $200,000 more. It's just that because of contract renegotiations and things of that nature, costs are higher. But yes, to your point, that services are being done now that weren't done last year or the year before. These are higher, more costly services happening.
thanks.
Mm-hmm. Any other questions?
No, you can go on.
All right. And the rest of the reports are for your guys to peruse through. And if you ever have any questions, I'll be here all day. All right.
Okay,
Thank you.
thank you. Where are we at? We have the wellness program review.
Good morning. I am going to provide an overview of what's been happening in the wellness program for the last year. So the on-site preventative screenings are still taking place. We've seen some increases with the healthy heart blood draws and the health risk assessments over the last year. A very slight decrease seen with skin cancer, cardiac and organ screenings, as well as the flu vaccinations. And just as a reminder, the prostate exams will start to be offered every other year now due to low participation. So they won't be offered this year, but they'll be offered in the following year. The three programs that are in place for employees are Hinge Health, Livongo, and Navigate. Hinge Health is the program that Rick was just referencing, the online physical therapy. So there are employees see wonderful improvements when they're utilizing the Hinge program. 46% see a reduction in pain. 72% see a reduction in anxiety, 56% see a reduction in depression. So it is a really wonderful program, and they're actually launching some new technology this year that we're really hopeful will make it more accessible to even more employees. Previously, when an employee enrolled in Hinge Health, they could only select one body part to receive feedback on. They would get a sensor, and they'd have to wear the sensor, charge the sensor, take the sensor with them if they were traveling. Hinge Health has released new technology where members can enroll up to 3 body parts at one time. They no longer need to use any sensors. So we're hoping that this new advancement for Hinge Health will just make it a lot more accessible to employees and encourage them to utilize it more as they have more options within that.
Can I ask a question about Hinge? Mm-hmm. So can you remind us how much this costs, the Hinge Health?
Yes, I think, John, do you have that information?
Well, the reason I ask, and it's by subscriber, right? So it's not paid by everyone. It's just it's being charged for that one person. So do we keep tabs as to whether or not the people who subscribed are still using it? It's almost like, you do a subscription online and then you forget about it and you're still paying it even though you don't use the service. I think that's what's happening. I've been hearing about that.
Okay.
So I think we need to, the staff, we need to maybe set up some kind of reminder and, just send an email to the people. Are you still using this service? If not, can you please, whatever you have to do, let us know or unsubscribe, because I think that's money that we could save.
That's great feedback. Yeah, Leanna and I can definitely have conversations about that. Thank you. Any other questions about Hinge Health?
Anyone? No.
Okay. Livongo is the program in place for diabetes, prediabetes, hypertension, and weight management. Some call outs for Livongo. Right now there are 105 unique users enrolled, and users can be enrolled in multiple programs within Livongo as well. Really, really great stats here. 62% of the users in the weight management program have lost weight, and 35% of those have lost 10% or more of their weight. And that's important to call out because that's kind of the threshold where people with weight management really start to see more significant changes in regards to hypertension and prediabetes. So for those employees who may not necessarily qualify to participate in Livongo or Hinge Health, Navigate is the program that kind of fills in the gaps. So it is available to everyone, but Navigate provides nutrition information, mental health information, financial courses, group challenges. We continue to see enrollment increase in Navigate as it is still the newest program. Just over the last 3 months, we've had about 40 new users enroll. So the enrollment continues to increase in Navigate, which is wonderful to see. And there are continued marketing efforts to promote the program. So the main areas that we see for opportunity are listed in the executive summary slide. What is really great to see about this is that there are programs in place for all of the major diagnostic areas. So exactly to the chairman's point, now our opportunity is really to continue to promote these programs so employees know that they're available to them and they can take advantage of them. I do have an update to provide today as well about the current skin cancer screening vendor that's in place. Right now, the vendor that we use is AIWW, and we were recently informed that they're changing the way they're doing their billing and screening services. So the current program in place right now is employees and dependents can receive a skin cancer screening that is covered at 100%. And screenings are about $110 per person, and Mohave County has about 5 screenings per year, not including the ones that are shared with close entities. So the change that AIWW making is they're essentially switching to a flat rate fee of $8,000 per screening. There's a $700 lodging fee and a $5 per mile round trip fee for anything that's outside of 50 miles of Tucson. This takes each person's screening from roughly $110 to $300 plus, which is obviously a massive, massive increase. I am working to find a much better replacement vendor, but my recommendation for this year is to skip the skin cancer screening and have a better alternative in place for next year. Does anyone have any questions or concerns about that?
Questions? None. Oh, okay.
What did we pay for medical costs for people with skin cancer this year, though?
I do not have the financial information for that. I can find that out and let you know. Mm-hmm. All right, looking ahead for the 2024 wellness program, we have the Hinge Health technology updates, which very excited to start to roll out to employees so we can get more employees taking advantage of that wonderful program. We have monthly wellness committee meetings, and this year I would like to do a wellness program survey, which hasn't been done for a while, kind of get a pulse on what employees know of their wellness program, maybe some opportunities to improve communication, and just gauge feedback on what employees feel is working well for them and areas we can potentially improve there. Continue to explore program marketing through new employee orientation and open enrollment, email campaigns, potentially implementing some new opportunities through city challenges, competitions, and discussion about a wellness club as well. So really just continuing to explore opportunities to grow the wellness program and make sure employees know really what's all available to them. And there is a health fair in the fall as well.
Madam Chairman.
Thank you very much for your time.
Yes, Susie.
Can I go back to the skin cancer? I have a question on that. Your recommendation is to skip this year and research a new vendor. When you say that, is it skipping the next fiscal year?
Yes.
2024 to 25? We're not going to have any vendor for skin?
Yes, that's correct. Unless something can be found in the meantime. But yes, that's a recommendation. There hasn't been a super great alternative presented yet.
Okay, so it's the coming fiscal year is what you're talking about to skip.
Yes.
Anything else?
Madam Chair.
Yes.
My concern with that is what we may experience the following year. If we defer it for one entire year, folks that that need it and don't have access to it are going to defer it until the following year. And in that case, the cancer conditions or stage can worsen, and the treatment then becomes even more expensive. There should be some form of some better interim solution, I would think. So, I would really appreciate an opportunity to entertain something that may not be as expensive as this option, but something less expensive than deferring and then incurring additional cost because of deteriorating or advancing cancer conditions.
Yeah, absolutely. And employees can go to their primary care physician and receive a skin cancer screening covered at 100%, but I do recognize how much more convenient it is to have it pulled up to their front door. So I am, in the moment, researching alternatives. Nothing has just been found at this point of time, but when a new vendor is identified, I'd be happy to bring it back as soon as that's done.
Do you have a number of how many employees utilized that service last time?
I don't have an exact number off the top of my head, and that's just because there's quite a few screenings that overlap with another group, and so the screening participation numbers are always a little mixed when it comes to that. I do know that in the past this has been a pretty well attended screening. I would be happy to dive up the exact numbers though.
Well, I just got a text from someone who's watching and said that if you go to your local provider, it's like $50 for a screen. So again, it comes back to like people need to take some responsibility for their health if they feel that they see something or feel something. And you say that we cover that 100%. So it's probably cheaper. I know the convenience of it, but again, that's just a huge jump.
Yes.
But, I understand what you're saying.
Yeah, and we just want to make sure that the vendor that comes into play next is really a great fit and didn't want to make a rushed decision when it came to that.
Right. Okay.
Madam Chairman. So basically, your recommendation is not to renew the current vendor for the next year, but you will continue to look for an alternative vendor that can be presented back to us so that we have a coverage for next fiscal year.
Yes, that's correct. Yes, the skin cancer screenings will come back.
Okay.
Bottom line is they just didn't want to drive up from Tucson anymore.
I think so.
Okay.
Thank you.
Next up, we have Blue Cross Blue Shield of Arizona, overview, discount, and utilization review. Hello.
Good morning. How is everybody? Madam Chair and distinguished trustees, thank you for allowing me to come back this year. Always happy to see you guys, and I hope you like your little gift. I'm Inspiring Health with the charcuterie / cutting board for fruits and vegetables. So I owe you one, and I have one for you. So you're not removed from the gift giving. So thanks again for allowing me to speak with you guys today. I'm going to skip through these to get to my deck. There we go. You guys with me? Okay. So I'm here today just to kind of share with you guys who your team is at Blue Cross Blue Shield of Arizona. Talk to you again about our Blue Foundation. Talk the numbers about the network value that we bring to Mohave County. So here's your team. We've got an open position on my team right now. That's why I'm giving you a smiley face there. But the smiley person will be joining us soon. We're still backfilling that position. But I am Rachel Martin. I am the Strategic Relationship Executive for Mohave County. I work very closely with John and Amanda when we get through the renewal negotiations and any network concerns that we have. Mike Greger, that you've met in previous meetings, he's our Regional VP of our Commercial Sales Division. A newer member of our team, Washington Covina. So if you follow me on LinkedIn, Wash and I are nearly connected at the hip with any and all of our public sector companies, conferences, businesses. He is really in charge and is driving our public sector vertical within Arizona Blue Cross. Being a local Blues plan, we feel this is the public sector is our opportunity for growth And we, being a Blue Cross Blue Shield entity, need to really drive that market because we all know that the needs are different. And it's tried and true. I have about 20,000 members under my belt in public sector. So public entities are close to me. So I wanted to talk about the Blue Foundation. We started the Blue Foundation back in 2018, and we continue to grow this program. I've had the luxury, and with the Blue Foundation, there are 4 pillars, but we're focusing primarily right now with 2, I would say, very aggressive goals for our Arizona population. One being in behavioral health, and the second in diabetes. So we know that diabetes is a chronic condition within our state, and we are charged to reduce diabetes progression by 25% in 2025. So at Arizona Blue Cross, we have built our own Blue Cross Blue Shield of diabetes site, as well as a behavioral health site that provides tools and resources. I've shared this with Tori, so your wellness consultant at Gallagher, to help utilize those tools and services. So of these 2, there are truly 4 pillars. The health equity component, as well as substance abuse disorder. I've had the privilege and the honor of having a virtual tour with Hildy and all of the great work that she's doing at Hildy's house. I would love to come back here next year and actually share and highlight Hildy's house as a grantee for Blue Cross Blue Shield of Arizona. So I'm fingers crossing because I keep nudging her. The application and grant application is valid. So let's get the application in so we can kind of lift that up and provide dollars to Mohave County. This county is the lowest dollar. We provided over $5 million in the state, and we've only provided $94,000 in Mohave County through the foundation. So I want your business, and we're going to make it happen. 22 million is what we've supported throughout the beginning of the foundation. So some of those folks that have received grant dollars, here's 3 of those examples. One of them is the Haven House, which is here in Mohave County, and it's a population that serves Lake Havasu School District for free and reduced breakfast and lunches outside of school, so summer programming. So we're helping to fund those programs throughout the year to continue to provide nutritious meals for that population. Lake Havasu School District is also a Blue Cross Blue Shield customer, so we're happy to serve them on not only as a customer base, but also for the good work that they're doing in the community. The next one is Arizona Youth Partnership, which is focused in Mohave County, Pima, and Santa Cruz. I see head shaking, so you guys are familiar with these organizations. This also is to help prevent and reduce the impact of substance abuse. So again, one of those foundations, right, building stronger family programs as an entity. The last one here is a statewide initiative called Local First Arizona that serves rural and tribal communities. And this organization helps grant funding so that they actually have the resources to serve their communities. They provide them resources on how to apply and write grants and then bring in those dollars to help serve their populations. If there is anyone on the panel today that is aware of any other charities or any other organizations, please come see me. As I mentioned, I would love to continue to drive charitable dollars that Blue Cross has available to them to this county. Mohave County is the fastest growing county. So let's start to serve the members that we have in our population here. So please come see me. You have my information also in the deck. Let's talk numbers. That's why we're here. So the network values. So when we're looking at the claims, it's always nice to make sure that right behind Rick, I'm nodding my head because he gets all the good stuff. He gets all the details. We simply price the claim and shoot it back to Ameritain for them to adjudicate the claim that has all of the diagnosis codes and all of that other fun stuff. So I just get a smidge. It's really hard to talk sexy about a discount when you get just a little piece. But anyway, let's talk about what we do get. So we had about $30.9 million that were totally billed to Blue Cross. The time period that we're looking at here is just a slight month off. It's November 22 through December of 23. But we had 30.9 million billed to us. Of that, our contracts allowed 12.7 million. The difference between that is the savings that comes back to the county. So that's 18.2 million. So that guarantees that difference right there is the percentage of the network discount. The network discount, so for every dollar billed, we're giving you 59% discount off that. So when we're evaluating networks, and I'm fortunate enough to continue to have your business, we're in a multi-year agreement for 5 years, and right now we're in the third. But when we're evaluating networks, it's really important to take a look at that 1 percentage point of a discount position. So we have our value at $309,000 just for 1 percentage point of a discount. So if we were to miss, or you'll see discount when I continue in the stack, 1 percentage point equals $309,000. If we were to see a difference in 5 percentage points, that's leaving about $1.5 million on the table. So you'll also see throughout my deck that we've been consistent in the mid to high 50s for the average discount, so we're doing a great job for you guys. When I'm looking at that discount position and the savings, I'm also trying to see what of what we call place of service in our industry. Is it inpatient? Is it outpatient? Is it professional? Where are we getting the biggest discount for you guys and the savings? So when I look at that 18.2 million, if I take you over to the far right in that chart, 48% of your savings is coming from outpatient. In Rick's presentation, 42% of your utilization had increased in outpatient. So like we're in sync with that position. That provided our discount just in the outpatient setting was 52% of every dollar that came in. That generated 8.7 million in savings for the trust. We had, as Rick mentioned, a pretty significant increase in outpatient. Our data shows 26%. And we also, as Rick mentioned, showed a decrease in claims. So it's nice to know that we're in sync, right? So negative 3% discount in claims from the previous year and a negative 3% discount in the discount position there. Any questions? This is what I call my return on investment slide. So when we talk about what's the value of blue, we're providing the 18.2 million in savings. The allowed amounts from our contract is the 12.7 million. My network value is 309, and what you pay me is 180,000. So you guys are getting a bang up deal on the cost for services and the value of the network that Blue Cross is providing to you. This is the historical shot that I was talking about. So you'll see a 5-year trend. And what I'm showing and trying to illustrate here is that even year over year, there were 2 years where we were not beating trend. The medical trend today is at 9% for Blue Cross of Arizona. In the previous years, it was 7 and 8, but 9 in 2023. So you can see we're in 2022 and 2023, we are still beating medical trend for the services that are provided and the discounts that we are allowing through our provider contracts. Then the chart on the far right just gives you an analytical view of year by year. You can see that discount position, as I mentioned, continues to stay in the mid to high 50s, nearly 60% for every dollar that's spent. You also see where we see a little bit of the decrease, increase, the ebb and flow of the membership count. And then you also see that network access fee is, again, what you folks pay for me to tap into our network, where we've come back significantly because we value your business, that we've reduced our fee over the last 2 years, and we'll continue with that through our contract. So as I mentioned, we're in year 3 of a 5-year deal. So again, thank you for your continued business, and let's do some work to get you guys some money through the foundation. So I'm really hopeful that we can do that for you all.
Thank you, Rochelle. Any questions? Nothing?
The only last one thing I wanted to say with this last slide, this again is what I would call my money shot. This has everything I've talked about in one slide. So it gives you the discount at 59%, gives you the savings at 18.2, and this is the claim distribution, like how many claims we received in that 12-month period. The bottom left column there gives you the discounts by each place of setting. That hospital discount, 70%. That's amazing. So as an aggregate, 59 for you all. And then just a comparison of where we were from last year. So thank you so much for your time. And good to see you guys, and take advantage of the cutting board charcuterie board, please.
Thank you very much. Okay, next up, we have the prescription drug utilization. And that is on, my numbers aren't matching up to my thing, but that's.
We're going to start on the red slide 87, if that helps. All right, good morning, Madam Chair and trustees. Thank you for having us. I'm Lisa Thompson, this is Jake Goll, and we're here to talk to you about the pharmacy spend with your prescription benefit. So you'll see on this first slide here, the time frame that we're sharing with you is 10/1/2022 through 9/30/2023. So we are showing you a full 4 quarters, but the reason we can't go through the end of 2023 is in the pharmacy world, rebates are a big part of the discounts that you receive. And with rebates, the quarter has to end. We send the data off to the pharmacy manufacturers, the drug manufacturers. They do their scrubbing and kind of working through that data. They come back to Navitus and say what rebates are available. We do our reconciliation, then we pay them out to the client. So that process all takes some time. So when they need their data, we don't have that rebate data for that last quarter available yet. So that's why you see that time frame. And then this next slide is just a summary slide, and so I won't spend time on this one. It's just there if you ever want to go back to the packet and get the high-level details of what we shared, you could easily find it there. So the next one, we're on the red slide 89. We'll talk about the details. So your plan paid was $1.6 million. Everything's looking great. It was actually 4.3% less than the time period prior. Your plan paid per member per month, and that is where you take the plan paid, you divide it by the amount of months we're looking at and the amount of members you have, and that normalizes the rates. You can compare yourself to other clients. So you're at $62.37. Again, that was also a decrease, so that's great news. And when you look at our benchmark data, and that's other similar public sector clients at Navitus, you're well below that benchmark. You can see it's $105.96. So things are looking great as far as you comparing to other clients and how they're performing. That has a lot to do with the rebates earned, the network discounts, and specialty drugs. And Jake will talk more about those drugs. Hildy, do you have a question?
Yeah, I have a quick question. So when you say there's a decrease, is that a decrease in the utilization, or how much is the end user paying more? Is that
No, the decrease is what you are spending on the prescriptions drugs. So what the plan or the trust is spending was less than the time period.
Okay.
So your costs have gone down. So then on the lower left of that quadrant slide, specialty percent of plan paid, we always want to look at that. That's a very important component. Specialty drugs are those drugs that are for chronic conditions, very expensive, and what really drives your pharmacy spend. So what really was a big component in the reduction was, you'll see that was 19.7% less than the prior time period. So almost 20% less in specialty drugs. And then on the lower right hand of that quadrant slide, generic dispensing rate. We always want this to be a little higher, as that represents generic drug utilization, which are usually those less expensive drugs. So you're at 86.7%, and you're above the benchmark, which is at 83%. So you're doing great in having members take generic medications. The next slide is a little busy, so I'll go through it a
Madam
little.
Chair,
Question?
Yes,
if I
Sam.
may. Would insulin be included in the specialty drug?
No, insulin's not a specialty medication, so it wouldn't be included in that specialty number you're seeing there.
Will we be talking about that later at some point?
We definitely will.
Okay, thank you.
That and weight loss drugs, which everybody wants to talk about. Okay, so back to the key performance metrics slides. The top part of the slide, I'll go through a little quickly. You can see that current period is that middle column. You haven't had a lot of change with your average invoice members, those utilizing the members' cost share and total scripts. Those all remain fairly consistent. But if you look at that savings section in the lower half of that slide, I would like to touch on those. So your network discounts for the time period we're looking at were $3.2 million. So that's the benefit of Navitus negotiating with pharmacies on our clients' behalf to get you better discounts. So that's a great number. Rebates, you can see we got you 30% more rebates in the time period prior. So $958,000 worth of rebates were passed on, which is also great news and the good work that Navitus does on your behalf. And then copay max, that's where we utilize manufacturers' coupons to save the plan money. And so you saved $117,000, which was 22% more than the time period prior. So great news in adopting that program. And you also adopted a program starting 1/1/2024, which expands that type of manufacturer copay assistance further. So that will even be better going forward. And then the last part of that slide, you can see the member paid portion was $926,000, the plan paid and the plan paid per member per month that we already touched on. Any questions on that slide?
Anyone have any questions?
No? Okay. And then this next slide, just very quickly, is a graphical representation of what I just mentioned. So again, it's all pretty good news. On the lower right, you'll see what increases your cost, the various components, and what decreases. And you'll really notice that blue rebate bar is a negative. That means that took down your costs. So that's a great thing, and the benefit of the rebates that I already talked about. And then on the left-hand side, most often we see specialty drugs driving your costs, but as I mentioned again, your specialty drug utilization went down, and that's reflected in that slide as well. So with that, I will turn it over to Jake. Thank you.
All right, good morning, everyone. Great to be back for another year. Great to see everybody again. Going to start to dive into some of the details on the drug-specific items here. And this first slide is just very high-level overview. Don't need to spend too much time on it, but it's just breaking down the individual drugs where you're seeing that copay assistance applied here. And you can see here they all have that little asterisk next to them. These are going to be the specialty medications, the primary specialty utilization. These specialty products are the ones that have the majority of the manufacturer assistance available on them. So to start off the drug utilization review, just a few kind of high-level overview slides. Lisa already touched on your generic dispensing rate, which looks great. This chart here is going to give a bit more of a graphical representation of how that trends across the year. And the main point of this is nothing to be concerned about with this graph. You see that dip in Q4. That's a pretty common thing for us to see for just about any plan. Q4 is when most members are getting their flu shots, and flu shots are technically brand name products. So you'll generally see that dip in the generic dispensing rate a little bit during Q4. Taking a look at the script cost versus script volume in terms of the plan paid amounts here. So again, this slide is going to really highlight the impact that the specialty meds have. But to first comment on that large orange yellow bar that's on the left-hand side, that's really where your generic dispensing rate is coming into play. So those drugs that are under $25, that made up 76.3% of your script count. And you'll see those ones that are over $1,000 are a very small percentage of utilization, script count in general, but due to the nature of those specialty medications and how high those costs can be for a single claim, that's where the majority of the plan spend comes from. And that's a pretty typical distribution that we'll see for plans right there. So now we'll start to get more into the details of the individual drugs, individual categories. So taking a look at the top categories by plan paid, and we're breaking this out first with the non-specialty category, staying at the #1 spot there, anti-diabetics. And I imagine there's a lot to unpack here. It sounds like there might be some questions. So I'll be sure to pause at the end of this slide and we'll get into that a little bit. But a few other things that I just want to comment on this slide, just to some specific jumps that we saw. So the antivirals having the largest PM trend there, that was largely driven by new starts on HIV medications. There are a few new members starting on those. I have a slide in the future that shows the specific meds. The good news with those, you all started that Access Guidance Services or the Copay Max Plus program on January 1st of this year. Those antivirals are actually, or those HIV antivirals are actually captured in that program. They do have manufacturer assistance available. So in the following year, we'll get to see the benefits that that program has for that specific category that you wouldn't have seen with the previous Copay Max program. And then one more comment on this, the ADHD category, seeing a jump into the top 10 there for you. You'll see you're aligned with our book of business now. That's usually a category that's in our top 10, and you can see the kind of jump in utilizing members there. There are a few reasons that people kind of attribute that to. One of the big things was during the pandemic, they relaxed prescribing rules for a lot of these controlled substances, ADHD medications. There was an act back in 2008 that put more strict restrictions on controlled substances, but during the pandemic, the relaxation was that a member could get these medications more easily through telehealth, just because they didn't want people going into their provider's office during the pandemic. That rule goes back to its 2008 status at the end of this year, so we'll be back at those more strict telehealth prescribing rules on those controlled substances. So I'll pause there because I know there's some conversations we want to have surrounding anti-diabetics. I'll open up to questions.
Any questions? So those ADHD drugs, is that like Ritalin and those kind of things?
Yeah, so Ritalin, we still see utilization of that. More commonly now, we're seeing Vyvanse as the popular one, and there's actually a generic that just came out for Vyvanse Q3 of 2023. So that's a fairly common one. Adderall, the generic, is another common one.
Is there a generic to Adderall?
There is, yep. And we see the majority of the members in this category using generics. Vyvanse has been a little bit tricky because, as I mentioned, that did go generic in 2023, Q3. But due to the increased utilization just kind of across the country with these products, the generic manufacturers weren't really prepared for the volume. So we've been seeing some pretty significant shortages, particularly on the generic Vyvanse, but other categories as well. And I know manufacturers are working on getting caught up on that right now.
Okay, thank you. Anyone else have questions?
All right, we'll move along to the individual top drugs by plan paid. So I'm sure everybody's familiar with,
I wanted to ask the question if the anti-diabetics is a broader name for medications that include the insulin. Much has been in the news about insulin and the fact that there's a monopoly and the industry has forced the prices to be higher than what it needed to be and all that. I understand that may have an impact on the cost of our trust, and just wanted to understand that, and if you can shed some light or share any of your thoughts on that matter.
Yeah, so I actually a lot to say. I feel like I could talk about anti-diabetics all day, but diving specifically into the insulin, that's completely true. There's been a lot of legislature, a lot of things within the government, I know, conversation surrounding these companies that sort of jacked up the price of insulin. I can say in 2024, so Navitas specifically did a switch where we were covering, prior to 2024, the Novo Nordisk insulin. We did a review in 2023 to look at costs, and we found it would actually be lower net costs for our group to switch over to Eli Lilly's insulin. So that's your Humalog and Humulin products. So with that, we did a pretty significant formulary change for 2024 to shift over to those lower cost products. Now, looking ahead, I'm sure there's going to be continued legislation coming out, continued conversations surrounding the cost of insulin within Congress, what have you. But I think with the anti-diabetics category, insulin is probably heading in the right direction in terms of costs. Costs are definitely going down with insulin. I think within the anti-diabetic category now, the bigger concern are those newer brand name products. So you think of your Ozempic, you think of your Jardiance, the stuff that you're seeing on commercials. So I have a specific anti-diabetic slide here, and you'll actually see that insulin doesn't even pop into your top 5 in terms of anti-diabetic products for plan paid amount. Generally, insulin now is starting to be on the lower end of cost for anti-diabetic products. And just surrounding utilization in general, because I know there were maybe some questions surrounding the number of members who are on insulin. And I looked, just comparing you to the other Arizona local government groups within the state as well, and you're right in the middle of the road compared to them. You have, in 2023, 1.8% of your population was on insulin, so nothing to be alarmed about there. The range that I was seeing with these groups was between 1 and 3%. So like I mentioned, you're right in the middle of the road there. I didn't see any concerns with insulin utilization. And the thing with insulin, too, is you're not going to see that abused just because of the side effects and the risks that come along with it. You know, it can bottom out the blood sugar. You're really not going to see members using insulin unless they absolutely have to be on it.
Thank you for that insight.
You're welcome.
Yes, Joy. Can you hear me? Okay. Just a question, since mental health is on the rise, I'm surprised that any of those drugs did not make the top 10, with people taking more drugs for anxiety and depression.
So antidepressants, anti-anxiety, if I'm recalling correctly, are in the top amount by script count, and that's a pretty common thing to see. The reason you're not seeing it pop into the plan paid amount is the majority of those drugs are generics that have been on the market for a while, so they're really low-cost medications. But yeah, that's just kind of what we commonly see. They're not going to be in the top in the plan paid, but in the top 10 for script count.
Okay. All right. Thank you.
That was a good question. Anyone else? Okay, thanks.
All right. So looking at the top drugs by plan paid here, those top 3 are the hot button items right now. So Ozempic, Trulicity, and Mounjaro. I see everybody smiling. I know we've all seen the commercials for those. But yeah, you'll see some jumps in utilization there with the exception of Trulicity. More members are tending to move towards Ozempic and Mounjaro, and that's largely because those are the products with better A1C lowering, so getting that blood sugar down better. And they also have some good other, call them side effects that come along with them, but they're positive side effects where they're helping a lot of the conditions that come along with diabetes. So there's great data supporting cardiovascular health with these. They're great at reducing the risk of heart disease. And of course, they do assist with weight loss as well, which in most diabetic individuals is a positive side effect. So something good to see with that. You'll see that big jump in Mounjaro there, that 0 to 16. The reason for that is because the prior reporting period, Mounjaro actually wasn't on our formulary yet. We were kind of waiting for more data to come out to support its use, and once it did, we actually added that to formulary 10/1 of 2022, so right after the previous reporting period ended. And then just to call out those products with arrows there, you'll recall I mentioned HIV as being a category on that previous slide, the antivirals where we're seeing increased utilization. Those specific products are your HIV medications right there. And as I mentioned, the good news with these is that there is manufacturer assistance available on all of those. So in 2024, this following year, when we're given this report next year, it'll be nice to look back and see the manufacturer assistance that you get on these that you wouldn't have previously received on Copay Max. Any questions on this slide at all?
What is Jardiance for?
That is also an anti-diabetic.
Oh, okay. Any questions? Proceed.
All right, so jumping into the rebate slide here, so you'll see this visualized. Those blue bars are going to be your plan paid amount, and those gray bars are going to be the rebates you received in that category. And the nice thing about those rebate numbers that you're seeing is that Navitus being a 100% pass-through PBM, we don't hang on to any of those rebates. Those are all going back to the trust. So what you see is what you get right there. That anti-diabetics category, the rebates, pretty common to see the rebates exceed the plan paid amount, and that's largely related to those GLP-1s, so Ozempic, Mounjaro, and then also the Jardiance as well. Since those are brand name products, no generic competition, those manufacturers tend to offer a decent amount of rebate on those products. So it is one of the silver linings of having higher brand utilization in that category. And then I just boxed the antivirals there to again stress that we'll see that that dark gray manufacturer assistance bar in the following year be a lot higher, just because you'll be getting that additional manufacturer assistance in that category. I did want to include an anti-diabetic specific slide because, like I said, could talk about it for about an hour. But one thing I just really want to focus on this slide is that chart that you may have to squint to see a little bit on the side there. But in October of 2022, we did want to kind of implement a process that would manage utilization of the GLP-1 products. We wanted to make sure, since a plan, for instance, like yourself, that doesn't cover weight loss, we wanted to make sure they weren't inappropriately being used. So at the pharmacy, we put in what we call a restricted diagnosis edit. And this requires the dispensing pharmacist. So a member will bring in a prescription, the claim will initially reject and prompt the pharmacist to type in a diagnosis code. Most e-prescriptions now will actually have the diagnosis code on it because it pulls right off the electronic health record. But basically the end result of that is you will only get a paid claim if it's a diagnosis code consistent with type 2 diabetes. So making sure we're sticking to appropriate FDA labeling on that.
Okay, so just for clarity, so if I go in and my doctor gives me Ozempic because I want to lose a few pounds, if I don't have diabetes, ultimately I'm going to be responsible for paying it, not the plan.
Correct.
Okay, good.
And the same with the people that are considered pre-diabetic?
Correct. Yep. So none of these products are actually approved for pre-diabetes, at least last I checked. So with that being FDA approved for type 2 diabetes, we restrict it to that diagnosis only. And then the weight loss products, or if they're using for a weight loss diagnosis, is going to be excluded from coverage altogether.
Pretty pricey drugs. Does the manufacturer have coupons for, are they allowed to?
So there are coupons available for these. Generally, you're not seeing a ton of assistance. Where you're getting the majority of the help on these is the rebate. So these are heavily rebated drugs. You can see the plan paid per script amount there on those. Generally, rebates can take that down anywhere from 40 to 60% off that price.
So if somebody's on these for their diabetes, and because they're taking one of these drugs, so Ozempic or whatever, and then their numbers drop, but they still have to stay on the Ozempic or whatever, then it's still not covered? Because I understand that it brings your numbers down enough if you're taking these that, you know, perhaps you would fall out of that category, would you?
Yeah, I would say that very rarely happens. Generally with type 2 diabetes, unless you've made some sort of drastic lifestyle changes, these drugs are going to pull your blood sugars or your A1C into a range that's acceptable essentially for a diagnosis of type 2 diabetes. But very rarely we're going to see the disease actually reversed. I actually have some comments on that on just a summary slide at the very end, some potential things to look at for the future. But yeah, that's the issue with type 2 diabetes as a disease state, is it's very, very difficult to actually reverse it altogether.
So you're telling me I shouldn't believe the commercials on TV?
It would be like cholesterol medication, right? So your numbers come down, but it's because of the medication
right.
that it's coming down. So you stay on it, you still have high cholesterol. That's your diagnosis, but it's being managed by the drug.
Right. So usually when you see going off of these medications, the numbers will just shoot right back up.
I know.
So that's why you don't want to be seesawing necessarily, is a lot of times, you know, like I said, yeah, you stop the medication, the sugars go right back up. This just provides long-term management. And unfortunately, that's just because to really keep those sugars down long-term without any sort of medication, it's going to require some sort of drastic lifestyle change, whether that's diet, exercise, what have you.
Any other questions?
All right. We'll talk about specialty here just a little bit. Fairly unremarkable specialty slides, as you saw your trend was down pretty significantly there. And with smaller plans, specialty utilization can have some drastic swings because you'll see the price tag on some of these specific medications. But chronic inflammatory disease is in the #1 spot there. That's your Humira, your Enbrel, those other commercials you're seeing. That's commonly in the #1 spot. One I did want to call out because people frequently have questions on this is the contraception category. They wonder how that's specialty. The IUD products are actually considered specialty, and per your plan design, those are covered under the pharmacy benefit. So that's why you're seeing that in there. And one more category I did want to call out, jumping in there, is cystic fibrosis. The next slide comments on the specific drug, but it's called Trikafta. That is a very high-cost medication, and unfortunately, that's a lifelong condition, so generally a lifelong drug that we're seeing utilized there. With that, fortunately, there is manufacturer assistance available through access guidance, so that does help out just a little bit with that high price tag. But to break down the individual drugs here, here's your top 10 for specialty. I do just want to comment on some of the new starts we're seeing there. So that first one in the #3 spot is the Revlimid, which is for various blood cancers, blood-related diseases. Trikafta, as I had mentioned, for the cystic fibrosis there. Kisqali is for breast cancer, and kind of echoing what's been said already by some of the other vendors, skin cancer there. I know there was a question on the plan spend for skin cancer, so we can give you an answer there, at least from the pharmacy benefit side, what you're spending. So you can see that Odomzo, that skin cancer drug, is going to be just under $6,500 per script. So to treat these cancers, these medications are very high cost as they're all specialty products, and generally they're targeting very specific mutations as well. Any questions on this slide at all?
Anybody? No.
All right. Similar slide here to the one we've looked at before. Again, just looking at the rebates received in this category, and then you'll see those additional darker gray bars, which is going to outline the manufacturer assistance that's available, just a little extra help on top of the rebates. And then I want to talk about Humira, because outside of anti-diabetics, this is probably the second most popular topic of 2023-2024. And the funny thing is, since I made this slide, there have actually been some changes. So what is noted on here, some of it doesn't actually apply anymore. But if you recall, early 2023, the first biosimilar was released, which is kind of a fancy name for generic of Humira. That was in February of 2023, that Amgevita product. And then this past summer was a big blockbuster release for a lot of other biosimilar products. So Navitus did a review in October of 2023, and we added those three on the left to formulary. Those are all the different biosimilars of Humira. We selected those just because they were the lowest net cost products. They're all the same active ingredient, so when we're reviewing this class, we just want to make sure we're picking the most cost-conscious ones to include on formulary. You'll see that Humira did remain on formulary at the time, and that was because it was helping out with rebates on other specialty products. So by keeping Humira on formulary, it actually kept overall net costs down for specialty as a whole. And this is now where the change comes in. So last week, Navitus just announced, based on different contracts, different rebate changes that came out, it now makes more financial sense to only cover these biosimilar products, and will actually be removing Humira from formulary on June 1st of this year. And just looking ahead again, our philosophy is always looking for the lowest net cost approach to any drug category. And by directing members to these biosimilar products, that's going to drive the cost down fairly significantly, just because they are a lot less expensive than Humira.
I have a question for the county staff. So for the people who are on Humira, do we let them know, or they just that this is going to be discontinued, or do they just walk into the pharmacy and and get upset about it. I mean, is there any education at all?
Yeah, I can talk through that because Navitas does handle a lot of that, and we reached out to Gallagher as soon as that change came out, sent our announcement just to raise awareness surrounding that. But we're actually putting letters together right now as a company as a whole, and those are going to be sent out prior to the end of the month. So members will have a minimum of 60-day advance notification that they're going to need to change to one of these products. So the hope with that is plenty of time to have that conversation with their prescriber. Last I checked, there were 8 members using Humira for Mohave County, so not massive disruption either.
But it's good that they'll know instead of
Yep.
being upset about it.
Oh yeah, we're all about proactively notifying them, so they'll be aware. Yep.
Madam Chairman.
Yes.
So would they have to go to their physician to get a new script? Or if I have a 90-day supply, could I just go into the pharmacy and they're going to give me one of these generics?
So these generics are actually not technically interchangeable with Humira. That's the tricky thing about biosimilars is these products are not yet interchangeable. So, typically with a generic, if a prescriber writes for a brand, we'll just use Zoloft as an example. Sertraline is the generic of that. Since they're interchangeable, you bring in a prescription for Zoloft, they can just substitute a generic right then and there. These don't have the interchangeability status through the FDA yet, so they would require a new prescription.
Okay, so get those letters out because
Oh,
you
yeah.
can't see a doctor in 60 days in Mohave County.
The hope with that, though, too, is that since these are biosimilars and it's the same active ingredient, these members can at least have a conversation with their prescriber, whether that's over the phone, whether that's through the MyChart. Prescribers are very aware of this as well. The hope with that is, you don't need to necessarily go in for an appointment to get a new prescription. Since prescribers are very well educated on these, my assumption and kind of what we've seen is they'll just send in a new prescription without an appointment, knowing that it is the same dosing, same active ingredient.
A lot of trust in our
Exactly. And anyone, you had a question, Susie?
My question is.
Oh, that was the same question. Okay.
And we can be flexible on that as well. We keep very close lines of communication with Gallagher. If we run into a situation, where a member isn't able to get a new prescription in that 60-day window, with approval from the trust, we can extend those authorizations on Humira if they need an extra month of it while they're still waiting for a new prescription. That's something we have no problem doing as well. So we have lots of flexibility there.
Anyone else? Sam? Okay.
All right, so one last slide on next steps, and it does sound like you have some great digital health programs in place already. I heard about Hinge and Livongo, so I won't spend too much time on this, but one that I just did want to touch on because we've been having so much fun talking about anti-diabetics is that Virta Health, and I noted weight management next to it, but they have a couple of different programs within Virta Health, and you can actually select to just implement a diabetes-specific one. The thing that I really like about Virta Health is that they're very focused on de-prescribing diabetes medications. So their whole goal is getting members to that point where they're starting to be around that reversal process. And they do that by working through various lifestyle changes, dietary changes. They're very in tune to the mental health side of it as well. So their clinicians work with members to kind of help them make those changes to get them off some of these more expensive medications. So that's just my little plug for them. Feel free to kind of just read these summaries. And if you want any additional details on these, happy to provide after the meeting, but these are just a few of the digital health solutions that Navitas has partnered with within the past year. And with that, that comes to a close. Any additional questions?
That was very interesting. Anyone have any questions? Mr. Barlow? No? That would be it?
All right.
Thank you.
Thank you very much.
Next up, we have dental and vision claims overview.
Hi, everyone. My name's Casey. I'm with Emeritus, your dental and vision provider. I am new for this account. I've been with Emeritus for the past 8 years. And then just because I've been telling everyone, I did get married on Saturday. So some
mazel
exciting
tov.
news. I've been, through these meetings, I've been kind of letting everyone know that it was coming up. And then now it finally happened. So exciting stuff. We have only been in force for the past 6 months, so a lot of the data we're going to be looking at is, I guess take it with a grain of salt. We need more to start getting trends and all that, but we do have some positive, things to point out with the data we do have. Do I have control, or you guys do? I have control. Okay, so this first slide, we're looking at total claims versus total paid claims. So this is the amount of claims that come in from everyone submitting their claims or charges, and then how much the county actually pays out. So you can see of all the claims that come in or that have come in for these first 6 months, $607,000. The county has paid out $251,000. And we'll kind of get into like how that breaks down in 2 slides. So out of all the 607,000, 29% actually get paid out. Now this next slide is we're basically adjusting for population. Again, this one will be more important as time goes on. The reason why we like to do this is so when we look at the true cost per member, we look at it, the paid amount per member and then just the total cost per member. This adjusts for population swings. So if we have a lot more members one year and claims look like they're higher, that might not actually be the case per member. So this just adjusts for that. Again, since we're only looking at the first 6 months, this is just a reference. Okay, dental claims breakdown. So on that first slide, I said we can kind of show how that works, how when 607,000 come in, the county only pays out the 29% of that. So the largest portion of that is going to be PPO savings. That's the Emeritus network, claims running through our network. All of your members receive a discount, and so that has a massive reduction in claims costs just there. And then claim savings, this is just looking at the claims that come in and denying things that aren't supposed to come in. Maybe members hit their calendar year maximum, maybe they're going in for a 5th cleaning and the plan doesn't cover that amount. Those type of savings, things that are submitted that aren't supposed to be. There's another portion that's not represented in here, and that's just the member cost through deductibles and coinsurance. So that's a small sliver as well. But in terms of the biggest pieces of the pie, this is how it breaks down. When I talk about the PPO savings, I also like to note it's a 34% PPO average discount. So of the claims that come in, our network discount on average reduces it by 34%. You guys could stop me if you have any questions at any time. And also save time at the end. So as we talk about the network, this is a really good slide to highlight. 90% of all the claims are going through our network, which for the first 6 months when moving to a new carrier, that's really great because people might not have adjusted to maybe finding a new provider. We have a really robust network, especially in Mohave County, but in the entire state as well. So being at 90%, only 10% of claims going out of network is a great number. Now, when we look at the top 25 providers, so we just saw 90% of claims going in our network. This is looking at the top 25, providers that have submitted claims, and as you can see, 23 of those 25 are in the Emeritus network, which is great as well. This next slide, we're going to look at how claims break down by type. So on all dental plans, there's type 1, type 2, type 3, and ortho procedures. Type 1 being preventative, your cleanings, your exams, your x-rays, all that stuff. Type 2 being basic procedures, fillings, getting a tooth pulled. Major is going to be your crowns, implants, those type of deals. And then ortho, of course, is orthodontia. I listed my target on the right side. The most important number I like to highlight is the 60%. Different dental plans, this is kind of a national benchmark of where we like to see plans at. The preventative is pretty universal across all plan types. However, basic and major can change depending on plan type. So I like to really just focus in on the preventative number. That's what's most important. You guys are just under 50%, which is actually pretty solid. I don't think I've ever seen somebody hit 60. My better groups are typically in the 50s. However, I do want to say take this with a grain of salt because it's the first 6 months. Highest frequency for cleanings is typically back to school season and end of summer, just across the board, and then also at the end of year. That's universal across all groups. So because we're in that first 6 months of typical high preventative use, it could shift as we get the last 6 months. But then everything else is pretty in line with what we would expect. Some additional facts on just procedures coming in. There are 723 exams, 1,057 cleanings, and if you adjust that for cleanings per member, it's 1.03. Again, that doesn't mean everybody got a cleaning. It means some people might have gotten 2, but that's a good number to kind of look at moving forward if we want to encourage preventative use and getting your exams, most importantly, getting your cleanings every year. We like to encourage that number to increase as much as we can. And then just some other facts in here: 56 crowns, and then fillings 336.33 per member. That's another one. It's usually interesting to see if we get great preventative use, utilization, and people getting their cleanings. You'll typically see that cleanings per member go down as well, assuming there's not high turnover in the group itself. For the fillings, that one's pretty solid. For cleanings, I would like it closer to 2. Again, we're in an ideal world. We're only 6 months in, so if people were to keep getting their cleanings, it could get up there. I don't have my target for fillings, but that's about what I see across my groups. I can find that though. Now, this next slide is return on investment. So this is looking at what the county pays emeritus, and then essentially what the return on. I like showing this slide. So you can see that at the very top there, that's the black bar. It's $21,000. That's what the county pays emeritus for access to our network, processing the claims, handling all the customer service that comes in for members, all that fun stuff. And then you can see PPO savings alone brought in $184,000 in savings. Claim savings was an additional $74,000. And then the 2 bars that I show beneath it are the ROI bars. I like to separate, ROI with just savings and ROI if you include claim savings as well, just if you want to differentiate between just what the value of our network is versus the entire picture. So those numbers are just basically deducting the fees from the PPO savings and the claim savings. You could see for every dollar that was spent, there was a return of $11. So not a bad investment. Next slide, we're gonna touch. We don't have much to talk about for vision just yet. Again, our data is really limited, so this is kind of my only slide on it. But I think it's important to look at. You guys have a dual network with both IMED and VSP through Emeritus. You could see the value in this, where both top 10 providers are in network for VSP and IMED. And what you could see is other than Jeffrey, who's number 1 in IMED and number 2 for VSP, there's a lot of difference between the 2 networks. So this shows that your members are utilizing each network to bring everything in network. Versus if we only had one, people would either be forced to see a provider they don't want to see, or they'd be going out of network. So it's a good slide to highlight that the dual networks working. And with that is
Any
my
questions?
presentation.
None. Thank you.
Awesome. Thanks so much.
Basic life, AD&D, voluntary term life, and short-term disability review.
Good morning, Madam Chair and trustees. Thank you so much for having us back. My name is Bill Oakes, and I'm with Oakes Inc. I'm going to talk about your Securian Life Insurance Plan and your Madison National Disability Plan. We'll start out with the life insurance, and on just a general comment, both plans are really running pretty well. We'll see that when we get into the numbers. This is more of a routine year, just giving you a quick review, and certainly happy to answer any of your questions. So we'll start out with the life insurance, and the county buys $50,000 of what we call basic or employer-paid life insurance for each of your eligible members or employees. And that really has another benefit to it. It's the accidental death part. So the way that works is, hopefully not, but if an employee passes away, that $50,000 would be paid to their beneficiaries. But you really have kind of a triple benefit going with the accidental death. So if it's a rank and file employee and they die accidentally, let's say in a car accident, that would double to $100,000. And if it's one of your first responders dying in the line of duty, that would triple to $150,000. Okay, so that's all included in the prices that we're going to talk about later. Any questions on the basic or employer-paid life? Okay, and then you allow your employees to say, "Hey, that's a great start, but I'd like to buy a little extra." So employees can buy extra life insurance on themselves, their spouses, or their children, and it's all payroll deducted. Again, 100% voluntary if they want to choose to buy more or not. And the employee can choose anywhere from $10,000 more all the way up to $300,000. They can buy up to $50,000 on their spouse, and they can buy up to $20,000 on the kids. Okay. I'm going through this rather quickly, but again, if anybody has questions, just tell me to slow down and I'll touch base on that. Okay. This next slide shows the rates. This is both the rates that you, the county, pay, and then the employee. So up on top is what it shows that you pay for that $50,000 basic life. It's 13 cents per thousand per month. And then the accidental death added feature is the 3 cents more for a total of 16 cents per thousand. Underneath that, you'll see kind of a chart showing the what we call age bandit rates for voluntary life. The voluntary life, the way that works is the younger you are, the less you pay. And as you get older, those rates do go up. So every 5 years, you'll see a new rate. And again, the thinking behind that is when you're younger, starting a family, getting a house, putting the kids through college, the rates are less expensive. And as you age, the rates do go up, but maybe your need for life insurance is not as great. The house is paid for, the kids have left home, etc. So again, as those premiums start going up, if you did have that $300,000, you might say, gosh, do we really need that much? And then you, on your own, if you decide to, can reduce the amount of coverage you have, okay? One thing I always like to point out, too, is that this coverage the employees can take with them when they leave. They can take any amount of the employer basic life and or the voluntary life. They just have to let HR know they want to do that, okay? Okay, and then finally is the child life up there. That's 20 cents per thousand, and again, you can buy 20,000 up to 20,000, so that would be $4 a month to get the 20,000 on each child. And again, that's $4 total. It's not per child. So if you had 5 kids at home, they'd all be covered for 20,000, and it would cost a total of $4,000 a month. Okay. Yes.
Question: is there a point in time when you reach a certain age wherein the supplemental term life insurance ends? Is it 70, 75, then you're not covered anymore, or you continue to be covered?
Yeah, good question. As long as you pay the premiums, you're covered. And by that, whether you're actively employed and paying it through payroll deduction, or when you leave the county, you can take it with you. And there's 2 different ways to take the coverage with you. These are insurance terms, but one is called portability, and the other one is conversion. Most employees take portability because it's less expensive. It stays as term life, but it does continue to go up every 5 years. And at age 80, that one does stop, but then you could switch to the conversion option. Conversion is whole life and it's more expensive. Some people do take it right off the bat because they think they're going to need it for a long time and it makes more sense to them to take conversion. But again, if they convert their life insurance, they can keep that indefinitely, as old as they get, as long as they pay the premium. Does that help answer that?
Yes, thank you.
Any other questions on the life insurance? Okay. Okay. These next two slides here, again, I think your HR staff does an excellent job on the life insurance, so thank you so much. Different employers, we have more of an issue with this, but on the life insurance, there's a waiver of premium provision. So if your employees become disabled, they can file a claim. And then both what the county pays and if they have any voluntary life, those premiums are waived until either A, they get better or they reach age 65. So again, it's kind of a nice feature you have in your life insurance. And then this slide here is talking about what we just talked about earlier. It's when they do leave, they can take the coverage with them, either through portability or conversion. The main thing they need to do is make sure within 30 days after they leave or their termination date is to request the coverage. After 31 days, that option goes away. And again, your staff does an excellent job of making sure they're aware of that. Okay.
Question.
Yes.
When you do continue your coverage after you retire or after you leave the county, would the rates be the same?
No, the rates are not the same. When they're with the county, the rates are, you benefit by this group rate that you have. And when you leave, again, most people take the portability, which is just slightly higher. It's still term life, and it's still probably much better than they can get if they went to get coverage off, on their own individually. The main thing you have going for you, however, is as long as you do it in 31 days, there's no health questions. You can't be turned down for any reason. Okay.
Thank you.
So, yeah. Okay, and this slide is hard to read, but it's simply a website that your employees can go to, and it gives them all the information they need, including the rates and the forms to either convert or port their coverage when they leave. Okay. Okay, so now how is your plan running? What have the claims been? And first of all, it does come out of rate guarantee next year. So June 30th of next year, we'll be working with your team at Gallagher and you to hopefully come up with another 3 or 5 year rate for you and visit with you about that. But overall, your plan is really running pretty well. If you look at, this is roughly a 3-year rate history here of when it started, but the first year was pretty tough, 188% loss ratio. But again, what year was that? That was in the height of the pandemic, and most of the claims were because of COVID. Then the next 2 years, pretty darn good, a 70% loss ratio, and then a 50% loss ratio. So those are what is more typical and historic of your county. When we do look at those numbers and we do provide numbers to the Gallagher team, we're going to take that first year and almost treat it as an anomaly because we don't expect that to happen again. So, so overall, your plan is running pretty darn well, and hopefully we can present some good things to you next year. Okay. Right,
Okay,
good.
sorry, I
Nope.
missed some of that, but is there any questions?
Okay, I'm going to go on to the disability insurance then. Again, the short-term disability insurance is 100% employer paid or paid by the county, and this is for your employees. The way it works is provides a weekly benefit to your employees up to 60% of their pay, not to exceed $2,000, $2,200 per week. Okay, so 60% or $2,200, whichever it maxes out at. The benefit starts after 30 days. So if they're sick or injured the first 30 days, there is no benefit. But after 30 days is when they'd probably apply for it within their first 15 to 20 days because, again, they probably know they're going to be out for a while. But after 30 days, the weekly benefit starts, and it would continue to pay until either their doctor says they're healthy enough to come back to work or until they reach that long-term disability benefit about 150 days out. Okay. So any questions how the benefit works?
Anyone?
Yep. No. Okay, and again, the next page is the rates. It's what 22 cents of $10 weekly benefit is what the county pays for it. And again, this plan is running very well too. Overall, since we've had the plan, really, really good numbers. Again, the first couple years, I think that's pretty much what your other guests have said, is that was during the pandemic and people weren't going in for knee surgery, so they weren't putting in a disability claim. But even after the pandemic, the plan has been running really well with the overall 36% loss ratio. So this one doesn't come out of rate guarantee until 2026. But again, hopefully we have good news to present to your team when it does. Okay.
Thank you.
Thank you. And that's really the plan. Any questions on the life or disability? I knew it would be fairly quick today, but.
Anyone have any questions?
Okay.
None.
Thank you so much for your, oh, yes, yes.
Wait,
Go ahead.
spoke
Yep.
too soon.
It seems like you're saying the short-term disability ends after a certain time when the long-term disability begins.
Yep.
Is a long-term disability related to ASRS?
I'm going to turn that over to Gallagher because do you guys, Amanda or
So
John,
they are
you know?
coordinated together
That's more
from
of a-
short-term to long-term?
No, it's
I think
just
Ken-
that when I said it ends when the LTD or long-term disability starts, is because that's the way you structured your plan. You said, look, we as a county are going to provide this really great benefit to our employees, but let's only pay for it when they need it. They don't need it after the LTD kicks in. But we don't represent your LTD plan, so I'm not really sure that answer. Do you know,
Ken
John,
is
how
there.
the state LTD?
Ken at the back.
Thank you, Ken.
Good morning. Long-term disability kicks in through ASRS. You normally, when the staff hands out the short-term disability paperwork, they also hand out the long-term disability paperwork in the same packet. And then, so if they go to the doctor, they only have to go one time and get both forms filled out. And then they go, sometimes depending on the severity and stuff, long-term can get approved before short-term just because of timing issues, and then the short-term will get up to long-term, then long-term kicks in and goes forward.
Okay, thank you.
Anyone else? Thank you.
Okay, thanks for your time today.
We're moving along here. Next one up is the review of actuarial renewal report and benefit change options. Chris Marshall, come on down.
Hello. Hi, Madam Chair and trustees. Thank you for having me. I'm Chris Marshall with Buck Consultants, which is a Gallagher company, so we're on the same team, so to speak, now. So I'll be going over the actuarial rates for the medical, dental, and vision plans for the plan year beginning July of 24. So our major assumption when we're looking at doing projections is the trend rates. So this is all things being equal, how much costs are going to increase by from the previous experience into the future. And it's an annualized percentage. And it's not necessarily only cost, but also utilization patterns and things. So if people are going and using different services more often or less often, then that can impact the trend overall. It's just an overall increase on a per head count as to how much claims we expect to go up by each year. So as for reasons described earlier, the prescription drug trends we've been seeing increasing a little bit more than what's been the past few years. So our trend rate is up a little higher for medical and prescription drug at 7.4%, and dental is 4.5%. We do separate analysis for each of the plans. We do combine prescription drugs and medical because they're under the same plan, but we will analyze those separately from dental, and then again also separately from vision. However, this year, because vision is a new plan, there was not enough experience to do an analysis on. There was only just a few months. When the plan first starts off, the claims aren't coming in yet. There's a lag. So we only had like 2, 3, 4 months really to look at. It wasn't enough. And vision can be a highly seasonal plan, meaning there can be ups and downs due to just the time of year it is. If people are off in the summer or towards the end of the year, they can get it in. When people are able to vision plan, you're able to put off maybe what you need a little more than dental, and then you're able to put off what you need on dental a little bit more than medical. So as you get further down, the changes due to just other things that tend to impact that more often. So bottom line is we didn't have enough to do a separate vision analysis. But for the other plans, we did a simultaneous projection of two 12-month periods. And we want a full 12 months because that gives you a whole calendar year. Sometimes there are fluctuations during the calendar year for medical and dental as well. So for calendar year 22 and 23. And these are just on the claims. So there's no administrative fees, stop loss fees, anything like that. This is just pure claims that we're looking at. So we'll get into what the analysis showed, but overall it's good news. For medical and dental, we are recommending a rate pass for the next plan year. And then we'll get into the details of that. For vision, because we didn't have anything to really analyze, we used factors kind of based on what the insured rate was prior to going self-funded. What we're doing is we're just conservatively recommending a 2.5% increase on the rate for the next fiscal year. On the development of the medical rates, so here we have the two 12-month time periods that you can see. If anybody would like me to get into the details, I'd be happy to, but I know not everybody likes the numbers as much as I do. So at the bottom of the kind of the boxes, it's the projected incurred claims, PEPM. And for the first 12-month period, it's $1,046. And then for the second, it's $1,016. So all in all, very similar. And these then get combined into one number, which is the 1,031 weighted projected incurred claims. And that compares to your current rates, which are the current composite premium rates of $1,064.79. So the projection is less than what you are actually currently collecting through funding. Therefore, when this happens, we tend to just recommend a rate pass and not a decrease. Yes, question?
I understand that you're not just considering the claims and stuff, but it's just surprising to me that when the rates are going down, you say no pass, remain the same, but yet if rates go up, you increase the rate. At what point when the rates go down would you say, oh, it's going down, so we would recommend a lower rate? Because it seems like even for the medical and the dental, it's the same way. Seems like the claims are down, but yet you're saying stay even on the rate. At what point are you going to be able to recommend and say, okay, it went down, we're also going to go down in rates? How is that justifiable?
It's for medical, it's very unusual to have this result. This doesn't happen very often. I would say if and it depends on the entity and what they want to do, but generally we recommend no increase because rate increases are hard and it's optics. So if you can keep the rate the same and then have a smaller increase in 2 years because the rate's going to go up next year potentially, that's better than having a decrease and then an increase. It just in the participant, the end user's mind. I mean, if you had a decrease of maybe double digits or 15%, something like that, then I think we'd want to look at maybe not going all the way to 10 to 15%, but reducing the rate somewhat. Does that answer your question?
Not really, but
Oh.
I understand you say there's a lot of factors you consider. That's why you're staying on the rate. But what are those factors really? I mean, when the rates are really going down, at what point are you going to say, you know what, it's reasonable to also decrease the rate at this time? And I understand your point of, you don't want to be surprised in the next 2 years, but that's in the future. We're talking about the next coming fiscal year.
Right. Yeah, generally, the claims tend to not decrease 1 year over another. I think the reason that we're in a good position is there was a large increase to the rates last year. And I think that's why we're looking at a decrease right now. I think the rates were increased for funding. purposes. So there was more consideration given than just having the rate being adequate to cover the next year. And I think that's why the rate is higher right now versus the experience. So does that?
Yeah, I'm not satisfied though, but that's okay.
Okay.
Okay, you sure you don't want to do a follow-up and get your mind at ease?
Oh, yeah. I mean, everybody says, in insurance, if things go up, it goes up. If it goes down, they never go down. They always remain the same. But what I'm saying is maybe there's some point in time where any of the decrease is really this significant. Like, for instance, the dental. It's negative 8.9. I mean, that's not just negative 1.2 or negative 2.
Right, yeah.
That rate, I thought it may be reasonable to say, okay, our experience in the last year or 2 years, is basically that. Maybe it's conceivable that we could decrease the rate this year.
Yeah, that's certainly, actuaries, we're conservative by nature, so we tend to recommend a pass. But yeah, you definitely could decrease the rate, especially on dental, if you would like. So with the dental plan, we had a 8.9% decrease was what the numbers showed. So yeah, I mean, if that's something that you would like to entertain, I mean, you could definitely do that. So
Can I ask a question? How much did we increase it by last year? The dental.
the dental was, there was no increase.
There was no increase. Okay. Oh, I thought you said because we increased things.
The medical, there was an increase
Oh,
last
okay,
year. There was
okay.
like a, depending
that's
on the tier and the
interesting.
plan, I think it was 16 to 18% depending on the medical increase, but not the dental.
Dental
Chair.
hasn't increased for like 3 years, has it?
It may have even been longer, yes. It's been a long time since that plan's changed.
Yes, yeah.
And I would just point out that these are just recommendations.
Correct,
The
yes.
ultimate decisions is ours. And so from an employer point of view, I would say unless we see a trend of 2, 3, 4, maybe 5 years where the rates are going down and we say, okay, we've built a reserve, we need to now lower the rate because it's unlikely that that is going to swing back up. But as long as it's a 1 year thing and the overall trend in medical, we all know where it's going. It's not coming. It's not staying level, and it's not coming down. So, it probably, as Chris said, and as I think as you acknowledged, Susie, there are a lot of factors. But this year, those factors produced this kind of outcome, but it's unlikely to repeat. And if it does, it would be great. We'll start seeing a trend with a higher degree of confidence that we can act on it. But I would, even if the recommendation was, well, we should lower it, I would be really hesitant to do so 1 year because increasing the rate, especially on both fronts, whether it be in the general fund impact or the employee side, is not an easy thing to do.
Okay. You don't look okay, but that's all right.
I mean, I just believe that the trends are always different. I'm not sure we could say there's a trend for the next 5 years. COVID came and went. That was a trend we did not anticipate, So I think, especially right now, we're in fiscal prudency is very much what we need to be in mind, I don't think we need to create a 5-year trend to be able to change something. Clearly, you showed a trend for 2 years, 22 and 23. That's 2 years. So how much more are we going to look for? Another 5 years to be able to say, yes, the trend should go down? I just don't see that.
Okay. Anyone else?
Moving on to the next slide for the dental, it's a similar story. The 2 years of the projected claims are very close to each other at 46.93 and 47.85, and then weighted together, those are 47.39, and that is a decrease over the current composite funding rates. So, and as has been pointed out, it has been like this, the dental has been this way for a number of years, where it's been, the numbers are showing a decrease. So if there was one to change, this would be the one to have a decrease if you're interested in looking at that. So. The next slide just shows the claim funding rates that are in force today, and then the low end and high end estimates kind of don't really mean much because they're the same as the high end is the same as the recommended, just because there was a decrease. But that would be the middle chart with the gray would be our recommendation for right now. So.
Any questions? Sam? Nothing? Okay.
Okay.
Well, thank you very much. Next up, we have the 2024-25 budget building and benefit change options. Mr. Hatz.
Thank you, Madam Chair, trustees. Patient while I navigate all these slides and get to where we're at here. Oops, I'm going the wrong way, that's why. Dan's at Buck. Okay. All right, so now that we've gone through all of the vendor presentations and the actuarial buildup, this is where now we kind of get to where the rubber meets the road, and we start to take all of that information and develop the budget as we're going to look forward to the 24-25 year. So outlined in your packet, I've put together a memo here that outlines many of the increases that we've seen that Chris has presented, and then it also has an illustration of all the fixed fees associated with running the benefits plan, administrative costs, stop loss, all of those things. And we'll get into what those dollar impacts here, but they're outlined here in your memo. No, I just heard. So as we get down, the next section here is we like to include a final budget from last year. So we include the 23-24. So one thing I want to make note as we go through these numbers, a lot of the numbers we're going to look at in the budget show what the recommended budget was. Now, as we know, we didn't get all the way to the recommended budget. There was a conscious decision where the rates are below what was recommended, so we have a shortfall. So we'll be looking at what does the recommended budget look like, and then various levels between where those funding rates are and where they really need to be to make sure that the rates cover all of the expenses. And there's some pretty significant differences in those right now, and we'll get into that. So just to kind of cover last year's budget, I believe the overall budget called for roughly about a 17% increase. What had taken place, the decision was to get halfway there. I think overall, through some contribution changes, some plan design changes, and some increase to the rates, we decided we got about 50% there. So again, when you're 50% there, you're moving forward also with you're carrying a deficit over, so you have to make that up in future years. This year, our estimated budget needed increase to completely close the gap based on the information that Chris provided using his claim funding factors is an overall budget of about a 10% increase. Now, specifically to the medical and prescription drug, it's a 10.8% increase. So that is to completely get to close the funding gap. So in addition to that, we've modeled out with the help of Luke and conversations with the HR staff, we've modeled out different levels of increases to either you don't close the gap, we keep everything at current, we get 25% there, we get 50% there, or we get 100% there. So we have some different things to look at as we go through these budget options, but I kind of wanted to give you that baseline foundation of what that starting point is, so it may help either develop questions or clarifications as we move through this information. So the next, I believe, the next item in your packet is a couple options that look at closing the funding gap. So what this option looks at is closing the gap by either 25 or 50%. What's not included here is all the way the 100%. Again, the 100% would be increasing your medical and drug rates by 10.8%. This is specifically focusing on medical and RX. I believe we can keep like a rate pass or even possibly a decrease on dental and vision. So this is really focusing on the largest part of your budget, and that is medical and drugs. So the first exhibit here, you'll see it has, I've simplified this. So you see the budgets that have a bunch of numbers in there. I've converted that into what we do to the rates. And then highlighted in yellow is the current rate and then a needed increase. So this first piece is bridging the gap by 25%. So as I mentioned, oh, go ahead.
Excuse me, you're referring to a slide, or what are you referring to when you say there's a gap? I just want to look at the gap. Where are we in terms of the slides, or you're referring to a slide, but I don't see any slide. Lost.
So where do I tell them that's at? Because I'm seeing it, but they're not up on the screen. We're not seeing that. How did this happen? Split screen and your batteries.
The additional pages? Yes. But would you put it up in the slide so we see what he's talking about? Oh.
The battery's about to go low.
Okay.
But what is the gap he's referring to? I'm looking. I want to see the gap.
The deficit.
Yeah. Sorry.
Last year, when we went through similar exercise, they recommended a certain rate increase. We discussed it, and we said because of the impact of the general fund and the impact of the employees, we deliberately cut it in half. So we created a gap between what we needed and what we acted on last year. And so we
Yeah, so I apologize. I was looking at information that you didn't have in front of me, so I apologize for referring to a slide that that you didn't have in front of you, or that information. So I've put it up here on the screen. So when I refer to the gap, it's the gap between the rates that were set and the rates that needed to be. The difference between those two is what I refer to as the gap. So that's basically what all things being equal, is what we think the surplus would draw down, because the rates are not covering the expenses by that amount. So you can see here where we note EBT monthly. that would be the gap. And so this top box is the gap from last year on a per employee per month by coverage tier, and that's how it's illustrated here. In that overall gap, to give you an idea of the shortfall that was estimated, was about 1.5 million. So these exhibits that I have in front of you are with conversations with finance on what would it look like if we keep the department budget the same. And if we were to pass on any increase to the employees at either 5.5% or 11%. But what you'll note here is that the department monthly, just the column to the left of the yellow, you'll notice in the top box is the current year, the bottom box is the projected year going forward, that those are the same. So this is of no impact to the department, so we wouldn't be increasing any department costs. So essentially what that is going to do is that's going to create a larger spread in the shortfall, right? Because we wouldn't be increasing the funding rates at the rate of the expenses are going up. So I'll kind of pause there and see if there's any questions.
Let me just understand a little bit. In the memorandum for the draft budget, the recommendation is medical prescription drug for both plans at 0%. But you're saying it's not translated into these numbers because there was a shortfall from last year.
That's correct. So when we talk about the 0%, the funding factor, that is Chris's estimated claims portion of the premium, that the claims that he estimated last year are not going up again this next year. So that's the 0%, but we're already lower than that. So you're exactly correct. That is the shortfall that still needs to be made up. I believe in testing my history of this, there were several years that there weren't any rate increases passed along. And so when costs continue to go up and you keep your rates the same, those costs will now exceed your rates. And so we fell behind. And so we have a shortfall, and that's where we're at right now.
Yeah, but didn't we use some reserve last year to make up the difference? So you're saying whatever reserve from the reserve of the trust to make up the difference to make it whole last year, correct?
You did buy down the reserves, but that doesn't impact the funding rates. See, so you accumulate a reserve, but the funding rates are designed to cover your fiscal year's worth of expenses. So if you don't have rates that cover those expenses, you'll draw down on your reserve. And so you get below, and the danger is there, you don't want to get your reserve surplus below the recommended actuarial amount, because at that time you could potentially have two increases. One, to get your rates back up to cover the expenses, and then a second component of that increase to replenish the reserves that you bought down. And that's the danger of buying down the reserves, to bridge the funding gap with the expense gap.
How much are in our reserves?
I believe it's about 8 or 8.9 million. Is that correct, Luke?
That's very,
At the end of fiscal 23, the trust balance was 8.2 million.
which,
Minimum actuarial reserve recommended at that point was 7.9 million.
right, so we were, yeah, we've been very good in our reserves since I've been on this
Yes.
trust. So, but again, I'm a layman, excuse me, but if it's going down on each of these things, why is it going up? Aren't we saving money when it goes down?
Your expected claims are going down, but the funding rates that you put in place are still lower than that. That's the gap that needs to be.
Okay, even if we make up this shortfall with a reserve, it's still going to keep going up.
Yes,
is what
that's
you're
correct. So if in a perfect world you go back in time and you increase your rates with inflation and didn't keep them flat, and you got here today, because the rates are flat or slightly going down, you would have a relatively small increase of, flat or a couple percent. But the fact that the rates have fallen behind, even though your claims trend is staying steady or even going down a little bit, your rates are behind, and those need to catch up, or you'll continue to spend down the reserve if you don't get caught up. So that's essentially what's happening.
So, Madam Chair, we had our reserve built up really nicely to like $10 million or higher. And for 10 years, well before I got here, we were in position that our rates were keeping up with the cost, that we did not have to do any increases, and the reserve continued to grow. The last few years, and if you recall from Aaron before John, and during COVID, we took a hit, but we said this was an anomaly. Our reserve is healthy enough, we can withstand it. But now the reserve has been coming down to the point where we needed to do something. So last year, we looked at a gap between what we needed and what we had, or where we were at. And we said, we're not going to do the entire gap in 1 year. That is not very thoughtful. We did something, but we deliberately did half.
Yes.
We said, what is the gap? And we delivered half of it, with the understanding that we would come back this year and revisit that gap and see if we need to if we can leave it alone or recoup the entire half or do something in between. Our balance now is down to 8.2. The actuarial is 7.9. That is now too close to comfort, and I think we need to make sure we don't draw up on the reserve and lower it below. So something needs to be done, is what I'm coming from, I think. And they modeled just doing something from the employee side and leaving the general fund alone because of what's happening with our general fund. I would be suggesting to the board that if we do something, and I think we should, that we do it both, we impact both sides, the general fund as well as the employees, and we can discuss what level we do.
Just for my edification, our actuarial, because I've been on this board now for 11 years, and I remember one of the first times I was on, and you always said that you were very conservative. And so that number 7.9, is that a very conservative number now still, or is that now, because of inflation, everything, like what's your definition of conservative, I guess I'm saying?
Chris, you want to?
Yeah, I want to engage that, because over the years we have done things based on your recommendations. And so now as we do this, I just want to make sure about that number as we have in other years.
Yeah, and that's a good point. And I think going back to what Rachel presented, and she mentioned that Blue Cross, overall the book of business, they're seeing about 8% trend. So that is in line with the assumptions that Chris is using. And so that's really what's going on in the marketplace, regionally, nationally, and more importantly, what Rachel is looking at in Arizona as far as medical trends.
Okay. Yes.
Last year we did 50%, correct?
Yes.
And approximately what was the dollar amount of that 50%?
So we will have to have staff bring that, because see, it varied for the different plans, but I think it topped off for the most expensive plan was under $50, was more on the $20 to $40 per employee we should have those numbers to refresh our memory, but that's what I'm recollecting from last year. So we went through the exercise of here's where we're at, we're past COVID, the risks are here, and in order to sustain the health of this trust, we should do something. And we debated it and landed on those numbers. And we looked at them for the PPO versus the EPO. And it varied. I don't remember them exactly. What I do remember is vividly saying, okay, we don't have to do it all this year, and we're not going to do it all this year. We're going to come back next year. So we should look at those numbers and refresh our memory. That's what I'm recalling.
I was just wondering how close we would be between the 7.9 and the 8.2 if we decided to use that money.
I think we're meeting early enough in the year, and we're still in our budget process, that I think the timing is good. We can debate and ask for as many scenarios as needed. I'll tell you, for example, what we're hearing from John is that 10.8 is what is needed overall. So we can do the 10.8, and based on all the criteria, that would close the gap. I'm of the opinion that we're getting close between the reserve and the actuarial, but we're not at or below. So I don't know that I want to do that personally. I don't know that I want to do the whole thing. But what I would ask is, if 11% closes the gap, and that is technically the half from last year that we did not do. What if we were to do half of the half? What if we were to do 25% and see what that would get us to, and what those numbers would mean total? What is the impact if we do half of the half this year to the general fund? What is the impact on the dollars to the general fund? And what is the impact on the employees? I think it's really important for us as a trust to understand that. And I'm as a member of this board, I'm of the opinion that we should, if we do anything, it should be a shared a shared break or a shared burden. So if we do an increase, we should split it between the general fund and the employees, so not one side is bearing the brunt of it. Or if we take a break, it should be shared as well. But I'm suggesting that we consider scenarios that keeps us healthy, but maybe not go all the way to 11%. Those are the types of debates that I'm suggesting.
Madam Chairman, going back to the question of my co-trustee regarding how much of that 50%. When we did the budget last year, those are budgets. We said 50% is coming from the trust. I think it's prudent for us around to look at that budget, the actuals of those budget, and say how much of that 50% was actually expended. And then move forward and say, okay, if this is where we are right now, then these are your recommendation. The 11% you're talking about is a shared increase. Is that what your recommendation is?
That's not the recommendation. That's just a data point to show you what the employee contributions would go up by and what the county's contributions would go up by.
So what you're saying is what could have been the county employees' contribution would be 11%, and 11% for the employer, which is the county?
Yes, so that would bridge.
So total is 22%.
No, everybody goes up by 11.
Oh, okay.
Everybody goes up by 11, and that's the number to say if we wanted to get rid of that gap and bring it to zero, that's our estimated needed increase to get there. And now we have modeled, kind of going backwards from 100% to say, well, what if we did a 50% this year? What if we did a 25%? And what if we can't stomach any increase? what does that do to the gap? So I do have some of those numbers to give you an idea of the magnitude between those ranges, because I have pre-modeled those out for our discussion.
But in your modeling, do you also consider the actuals? What is the actual budget that was used for last year, of which 50% came from the trust?
We do have some actuals that, from the budget working with Luke, but our estimates for projecting going forward are based on the actuarial's projections, and then building up the rates with all the other components of managing the health plan, the administration, the stop loss, all of those things, and then comparing it to the current rate, and then what is the difference between those two. And that's where I'm coming out at the 11% or 10.8%. It's hard to strictly look at actuals as we're only 6 months through the current fiscal year. A lot of things can change. Your fixed costs won't, but there is a ton of variability in the claims costs. As you saw the reports before, large claims, they don't have seasonality or timing to them. They just randomly show up, and they're your largest exposure. And that's one of the reasons why you have a healthy reserve, is to be able to absorb those unexpected claim fluctuations. So that's where we rely on Chris and his work at looking at 36 months or 48 months or 12 months of data, trending that forward and coming up with our best estimate, and then comparing to where you're at today. But what we can't necessarily predict with certainty is where this budget is going to end up as of 6/30. We can fill in the last half of the year and get an idea of where we think we'll have, where we're going to end, but that doesn't necessarily come into play with what we think is going to happen in fiscal year 25.
John, Madam Chair, the numbers you're presenting today leading to the 11% recommendation do integrate and factor in the increase that we implemented last year.
Correct. That is correct.
Okay.
Okay, anyone else? You can proceed.
I think all of the questions and all of the discussion as we had kind of covered that preliminary budget built out. I know we're going to break and then come back and talk about it in more detail or make recommendations, but that really covers the discussion portion of where we're at as far as building the budget out.
Madam Chair?
Yes.
So looking at the two that we were handed, the two sheets, the one that in red says 1.11, which that's the 11%. The other one is the 1.055, which is half of that. I'm just so I understand these numbers. In the yellow, I'm on these two sheets. No, I know. Okay. The current total rate, the column that is highlighted in yellow, for the 1.11, at the top for the employee, it shows 765.92, and to the left of it is the department, which is 682. And down on the same sheet, but the lower half for FY25, for the employee, it would show 850, and the department would monthly would be 682. But that is because you told us up front, you modeled this one with the understanding that there would be no impact to the department or the general fund, and the impact would be on the employee side.
That's correct. So this was one of the alternative scenarios that we were asked to model, that what does it look like if say 5.5% increase got passed off onto the employee, or 11% increase got passed off into the employee, but if we had to keep all department costs at the same as current levels, what does that look like, and what does that do to that gap?
And I'm with you. I'm not suggesting
Yep.
anything in my comments other than to understand.
Yep, and you are correct.
So this difference between 850 and 765, I'm in the yellow highlighted column, and in the difference between the FY24, which is 765, and FY25, which is the 850. The difference is $85. If we were to go with this option, and I'm not suggesting we would, I'm doing it to understand. The difference is $85. That's $85 annually, correct?
Monthly.
Monthly.
Monthly. It is monthly.
Monthly. So in this scenario, if we're looking at the
That's if everything goes.
the 11%.
No. So so 80 for FY24 it's 7. I'm not seeing where the difference. So currently in FY24, what it is now, it's $765.92, correct?
Yeah, that's the sum of the employer and the employee
Right.
component, correct?
What we're proposing is it would not proposing, but the scenario you're modeling in FY25 with the 11% increase on the employee side would take it from $765.92 to $850.17.
Is that the whole thing?
No. And that's what I did not add up. And I apologize for that. If that would actually take that employee only to $770.49.
Okay. This is where I think we just need to quantify what these percentages are, Madam Chair. Whatever the percentage is, I want to reduce it down to a dollar amount. So we understand, for example, if we go 11%, example, $500,000 to the general fund and $30 per employee. Or if we go 5.5, which is half of the 11, it would be $250,000 and this many dollar per employee. I want to.
That's what we're doing later. Like, aren't we going through all those scenarios, or is that what we're supposed to be doing now?
This is really the time where at least we understand now, so we can tell them, go model this or that, Madam Chair, so we can vote on it at some point.
Yeah. Just a little. Yeah, be kind and generous.
Yep. Okay. So Sam, to get back to your point or your clarification on here, keeping the employee the same or the department the same and increasing the employee portion by 11%, that takes the employee from, I need my readers, 83 to 92, right? Yeah. Yes. Yes, a month. Yep.
Yeah, we're only doing, we're going to do the whole thing. We haven't talked about if we're doing incrementally.
Yeah, if we so the recommendation in front of us to close the gap is 11%. What he's telling us now, after consulting with, the 11% increase, if applied only on the employee side, would be $9 a month more.
So it was annually.
More to the premium. Not pay period, but a month.
Yep, that's correct.
In addition to the current premium, correct?
Yeah, it's just above it.
$9 increase.
But it wasn't
to
like
what
the
it is now.
$79 that we said before on a monthly, right, so that makes much more sense.
10%.
Yeah, yeah.
So the $40 a month.
Right.
Just for clarification.
Yep. And so to go in that was the employee only. So to give you a range on what the highest would be the EPO family. So an 11% change to the somebody in the EPO family would be about $40 a month. Yeah, because So just to give you a range of the single only to the family, it goes from $9 to $40 would be the impact in that plan, assuming that scenario. That's correct. So that was just one of the scenarios that we were modeling on if some of those increases got passed on to the employee only and the department levels remained static or at current levels.
Well, I assume the numbers here, current total rate is monthly or yearly?
The current total rate is monthly. And then what's labeled EBT monthly, that would be what I kind of have been referring to as the gap, the difference between where the funding is and where it needs to be. So that's what the EBT is funding or the trust is funding.
Madam Chair. John, it would be helpful if we expand these tables or the spreadsheet just enough to take the current for us to help us understand it. For example, for FY24, the current year that we're in, if you look at the chart for employee or employee plus spouse or employee and children and so on, those four rows, for each one of them, we have the header census, biweekly, monthly, department monthly, and then current total rate. I think it would be really helpful for the scenarios that we model to say if the current monthly is 83, what would the new monthly be? So we're seeing those numbers and relating to them as we evaluate what to do. And so we can do that we can do it as you have done it here, just the employees, not the department, for 11%. And then do one, you have two, but both of them, the employee is carrying the difference and the department is held harmless.
On these two, that's
On
correct.
these two.
Yes.
What I would be asking the chair to and the board to concur with is to do two more that would say, what if we were to share that burden between the employee and the general fund for a I would do the two that you have, 11% and 5.5%, and then I would try two more in between them.
This is the card.
Maybe like a 3% and an 8%, and just to get a feel. What we're really trying to do is balance out the closing of the gap with the burden on the general fund and the employees. Is what I keep coming back to.
Okay. And if we do want to look at that, I already have those pretty much modeled. So as after break, if we want to bring those up and look at what sharing those increases equally, basically just taking everybody up by, say, 3% or 5%, what does that look like? What's the impact to both the employee and the employer? I do have those modeled and ready to go.
Do you also have it per pay period, what it will actually look like coming out of a paycheck?
Yes, at least on the employee side. So
Yeah, that's what I
the
mean, on
far
the
left
employee.
column, just past the census where it says
Yeah.
employee biweekly, that would be the per pay period.
That's,
Oh, got it.
yeah.
Okay,
It's listed that way, Madam Chair.
I would like to see something that first uses the difference between the 8.2 million and the 7.9, use that figure, possibly reduce the dental that hasn't been reduced, and then figure out what the 5.5% or 11% would be.
So buy down the difference in the actual reserve plus the actuarial recommended reserve, buy that down intentionally, and then model the increases to get to where we need to be.
And possibly even throw in the reduction in the dental as well. Hoping to, just get this more at a level so that our employees can't take any more paycheck cuts.
We should look at all options. I just hesitate to reduce the reserve down to what the actuarial is, just because that would mean we would have very little room for fluctuation in the future. We've enjoyed a healthy reserve balance, which far exceeded the actuarial recommendation over the years. I'm only speaking as one board member. My preference would be to not draw down on the reserve completely
But
and
this
model the various.
What we've been talking about is to cover the whole deficit. So we haven't even really looked at the other scenarios
Indeed.
in this small. So I assume we're going to do that after the break.
Yes.
Okay.
Yep.
All right. So are you done with your part of the presentation now, or is there something else before we break?
Nope, that's it all for now, Madam
Does
Chair.
anybody have any other questions about this before we take the break?
Madam Chair, I don't have any more questions
Sure.
myself.
Okay, well, we are a little ahead of schedule, so that's why I'm asking, is there anything we need to talk about? Because we do have this time. Any of you want to come up and say more? I don't see anyone jumping up.
I'm more than happy.
You want to tell us about your wedding? Okay, all right.
So, Madam Chairman, in your memo attached to the packet, those are the options you're looking at, and based on this option, this was developed, right? So, if we're looking at other options, obviously we're going to have a different spreadsheet on what those options would show.
Yes, yeah, that's correct. They're outlined. They just weren't, printed or part of the packet, but they are modeled.
Okay, thank you.
We'll be able to see it on the.
Yes, we'll be able to put them on the screen and navigate through all of those different ones. And hopefully I made this easy enough that I can make some adjustments on the fly and model some alternatives in real time.
All right, well, if there's nothing else then, are we set up for lunch, or because it is early? We do, good. And then so we allot ourselves 45 minutes. So we should be coming back here at about 12:30. Okay. All right, we'll break for lunch.
I want my packet back.
Yeah, that'll be the next one, but we have to look at some stuff because we need to look at where some of the differences. because I'm not.
Somebody asked him what his name was, and he said, "You don't know who." Okay. We're waiting on the straddlers. That's all right. Okay, so we are the trust meeting. Okay. We're going to reconvene this meeting. It's the trust meeting. And let's see, we are on tab number 12, 13. What is our tab number? 14? I think it's 14. Is it 14, the tab? Gosh, I just got a paper cut. Gosh. Okay. Oh, so now we have to start over. All right. So I'm calling the meeting back to order. Official business come before the board, called to public. Anyone? Love it. Closing the call to public. Discussion, consideration of, and possible action regarding member denial. Agenda item number 2, we may go into an executive session pursuant to ARS Section 38431 to discuss personal private health information. So do we need to do that? We need to go into executive session? Yes. I'll need a motion.
So moved. Second.
All in favor?
Aye.
Opposed? Motion carries. So everyone who needs to leave, leave, and they know to turn off all this stuff up there.